Inside a microscopic capillary, billions of red blood cells are in constant, rapid motion. When we draw this blood and run an automated complete blood count, or CBC, machines rapidly quantify this environment. They calculate the total cellular volume, measure hemoglobin concentration, and output raw numerical counts for the major cell types. But automated flow cytometry has a distinct blind spot. Flow cytometry is a laser-based technology used to count and profile cells in a fluid mixture. While it excels at registering physical size and total quantity, it cannot evaluate the structural integrity or precise shape of individual cells. To bridge the gap between a raw numerical spreadsheet and a definitive clinical diagnosis, a physician must turn to a qualitative tool, the peripheral blood smear. A technician places a drop of blood on a glass slide, spreads it into a thin monolayer, and applies a Wright Giemsa stain. The Wright Giemsa stain is a hematological mixture of dyes that colors specific cellular components to make them visible under high-resolution oil immersion microscopy. Under the lens, specific deviations in cellular structure act as highly sensitive visual markers for underlying systemic pathologies. A purely quantitative diagnosis relies on statistical assumptions about the cause of a low or high count. A qualitative diagnosis visually confirms the specific etiology. Etiology is the precise cause or origin of a disease. To build this diagnosis, clinicians systematically evaluate 3 primary cell lines on the smear: erythrocytes, leukocytes, and thrombocytes. Trusting only the automated numbers without viewing the actual cells leaves diagnostic gaps. Examining the physical shape of the cells makes the peripheral smear a mandatory clinical tool for accurate patient care. This diagram displays a split-screen comparison. A healthy normocytic cell on top has a standard uniform size and distinct, lightly colored central pallor. The first deviation occurs when a cell simultaneously diminishes in overall diameter and loses internal hemoglobin, causing that pale center to expand. These small, pale structures are classified as hypochromic microcytic cells. Observing this specific presentation maps directly to a diagnosis of iron deficiency anemia. Contrast that presentation with the exact opposite structural anomaly, a cell that is significantly enlarged and distinctly misshapen into a stretched oval. These are macro-ovalocytes. When a red blood cell takes this enlarged oval shape, it indicates an underlying impairment in the body's DNA synthesis pathways during cell maturation. The presence of macro-ovalocytes indicates a clinical etiology of severe vitamin B12 deficiency. The most critical erythrocyte anomaly is the result of mechanical fragmentation. When red blood cells are forced to cast rigid obstructions within the vascular system, they shear apart. The resulting fragments are called schistocytes. Under the microscope, they display a characteristic, irregular, jagged shape, often resembling a broken helmet. The presence of schistocytes is the definitive visual marker for active hemolysis. Hemolysis is the mechanical destruction or rupture of red blood cells in circulation. Identifying even a single field of schistocytes on a smear immediately escalates a routine anemia workup into a life-threatening clinical emergency, requiring rapid intervention to stop the mechanical destruction. Moving to the leukocyte cell line, we examine the internal structure of the white blood cells, starting with the mature neutrophil. This schematic shows a normal neutrophil cell. A healthy neutrophil features 3 to 4 distinct internal lobes, connected by thin chromatin threads. The strict threshold for abnormality in a neutrophil is the presence of 5 or more distinct nuclear lobes. This presentation defines a hypersegmented neutrophil. It is a highly sensitive marker for megaloblastic processes. Megaloblastic processes are conditions where impaired DNA synthesis leads to the production of abnormally large, structurally immature cells. Connecting this back to the erythrocyte line, the hypersegmented neutrophil serves as a dual marker, confirming the severe vitamin B12 or folate deficiency initially suggested by the macro-ovalocytes. Evaluating a completely different leukocyte line, the lymphocyte, reveals an entirely different class of pathologies. This diagram illustrates a resting lymphocyte. It maintains a highly compact shape with perfectly round outer borders. When it enters a reactive state, its cytoplasm expands rapidly,
and the one's smooth borders become irregular and pliable, molding their shape around adjacent cells. These enlarged, spreading cells are classified as atypical lymphocytes. This expansive morphology maps to a reactive viral response by the immune system. Specific viral etiologies trigger this exact morphological shift, most notably the dengue fever virus and Epstein-Barr virus, or EBV. EBV is a common human herpes virus known for causing infectious mononucleosis. Analyzing leukocyte morphology allows a clinician to visually distinguish between a patient suffering from a chronic nutritional failure and one fighting an active viral infection. Shifting the microscope's field of view down reveals the smallest cellular components in the blood, the thrombocytes, commonly known as platelets. This scale diagram shows the baseline size of normal platelets, appearing as tiny dots that are a fraction of a standard red blood cell. The primary variant is the giant platelet, achieving a massive size that approaches the diameter of an entire red blood cell. Giant platelets indicate that the bone marrow is producing new platelets at an accelerated rate, releasing them into the bloodstream before they have fully condensed in size. This rapid bone marrow production is a hallmark sign that a patient is entering the recovery phase following a severe dengue infection. Conversely, thrombocytes can create misleading clinical scenarios, particularly when an automated CBC report returns a dangerously low platelet count. This simulated flow cytometer shows in vitro platelet aggregation. Normal platelets chemically react to laboratory fluid and stick together before reaching the counting laser. When a clump of adhered platelets passes through the aperture, the machine misreads the entire blockage as just one single cell. This laboratory artifact is called pseudothrombocytopenia. It is a false low reading, caused entirely by mechanical clumping in the test tube, not an actual platelet on a peripheral smear, intercepts the error and prevents a healthy patient from receiving unnecessary treatments for a fabricated bleeding disorder. Pulling back from the isolated views of individual cells, the entire peripheral blood smear functions as a complex, unified diagnostic landscape. This matrix displays the three overarching categories of morphological findings: chronic deficiencies, mechanical emergencies, and laboratory artifacts. Across this landscape, specific morphologies in different cell lines overlap to confirm complex diagnoses. Finding macro-ovalocytes in the red cells alongside hypersegmented neutrophils in the white cells provides a multi-line confirmation of a B12 deficiency. The smear also plays a non-negotiable role in catching hidden physiological crises. Identifying a field of schistocytes reveals active hemolysis that raw numbers might obscure. Routine smear reviews offer patient safety benefits by ruling out machine errors, like pseudothrombocytopenia, keeping patients safe from unwarranted medical interventions. The ultimate utility of these two tests is strictly divided. Automated CBC data indicates that a problem exists, while the qualitative smear analysis identifies exactly what the problem is. This creates a definitive clinical role. Any severe or unexplained deviation in automated CBC numbers requires an immediate manual review of the peripheral smear. This rule extends to the physical presentation. Whenever a patient's symptoms contradict their automated lab numbers, a visual cellular check resolves the discrepancy. Despite modern advances in automated cytometry, the human eye analyzing morphological reality remains the definitive arbiter of hematological diagnosis.